warm welcome to Dr. Krishnamurthy, District Surgeon, Hassan District. And with a happy note, I would like to share with you all that we had excellent sessions in the previous 3 days. And on day one, we had a very good interactive session and presentation from Dr. Smita Nambiar, Medical Director from UAE. She spoke about Ayurvedic guidelines to combat COVID-19. On day 2, that is on 20th, Dr. Shashikant gave a wonderful presentation on genetics of human immunology. Yesterday, that is on day 3, Dr. P.C. Shrikant shared his outstanding research work on photonic biosensors with special emphasis to COVID-19, which is a very, very promising area of research. Today, that is the day 4 of this international webinar series, we have with us Dr. Vidya Ponnathpur, who is presently working as Chief of Cardiology, St.Luke's University Health Network, Monroe Campus, Pennsylvania, USA. So we'll be delivering a talk on success of COVID-19 in human population, threats and challenges, a much awaited one in this COVID crisis. Dr. Vidya Ponnathpur hails from a Jodidar family of Ponnathpur, a village which is submerged during the construction of Hemavati Dam at Garur in Hassan District, Karnataka. A brilliant guy since his childhood, he did his primary schooling at Hassan and joined Bellary Medical College to pursue his medicine, and he got the Government of India National Merit Scholarship to do his medicine. He received the Defense Scholarship of Indian government during his PG residency. He is a recipient of many awards and fellowships. He is the recipient of the award Intern of the Year from the Department of Medicine, Medical University of South Carolina, Charleston, South Carolina. He received Clinical Research Fellowship Award from American Medical Association, Research Fellowship Award from American Heart Association, Virginia. He has board certification in cardiology and CVD, nuclear cardiology, internal medicine, etc. He has medical license from the states of Pennsylvania and Virginia. His professional training include diagnostic cardiac catheterization, nuclear cardiology, echocardiography, and transthoracic and transesophageal echo, Swan-Ganz catheterization, pacemaker, AICD follow-up, carotid ultrasound, etc. And this is just a brief introduction about today's speaker, Dr. Vidya Ponnathpur. With this brief introduction about our speaker, I would like to extend a warm welcome once again to you, sir. And I just hand over the session to you, sir. Over to Dr. Vidya Ponnathpur. I request you to start the session, sir.
Thank you very much. Audio is clear?
Yeah.
Okay. So I really thank the organizers. This is actually a very unique and well-balanced and all-encompassing topics, Ayurveda, genetics, photonics, allopathy, and artificial intelligence coming up tomorrow. It's, I think, a very unique concept. I have to really thank the organizers for coming up with this unique concept. I was introduced to 3 organizers this morning, and I think that'll set the tone for the whole COVID crisis and humanity. One of them is Soumya, her name. It means calm, kind, cool, collected. We need that in this hour. Second one is Jisha. Jisha means hope. That means we have to have hope. And then lastly, Dr. Shubha means auspicious. That means we should have an auspicious ending to this pandemic. So with that brief introduction, I really want to tell you this, that with this information superhighway, information and misinformation, there is no dearth of information. So what I would like to do in the next 40 to 45 minutes or 50 minutes is to give you some broad outline, because the audience is diverse. So we need to just cater to each section of the audience. Some are biology, some are technology, some are physicians, where they think that this could be very basic for them. So we need to just get everybody together in this journey and hopefully give you some practical tips. What's most important thing to remember is that we still don't know. We are less than 1 year from knowing about SARS-CoV-2. So that is my brief introduction. So let's go through the origin and the structure of the virus. I am not a virologist, but I think it's very important to understand the viruses. And then, what are the clinical symptoms, the treatment, the non-COVID effects, and then finally, what is in store, how we can at least, if not break the pandemic, subdue the pandemic. So as you all know, this was reported in December of 2019 in Wuhan, China, was the first reported incidence of cases. And then you all know the chronology of events, the outbreak of cases in Europe, Iran, and then the United States, UK, and finally WHO ended up declaring it as a global pandemic in March of 2020. As of yesterday, there are 9 million confirmed cases. These are documented. Obviously, I would say the numbers are much higher because of various things, testing capacity, local regulations, and so on and so forth. This number is documented, but I'm sure you all know that this number is much higher, close to 500,000 deaths. I think that is why we are here. If it was just a simple infection where people recovered, we wouldn't even be talking about this. I think mortality is the one which drives the whole thing, because that you can't do anything about it. So that is the most important part, is the 500,000 deaths which has been caused. So coronavirus is a family of viruses. It's been there. Obviously, we never knew that coronavirus was that popular till this COVID-19. It's a family of viruses that infects the animals and humans alike. As you can see, the outer protein look like a crown of spikes. Corona means crown in Latin. That's why it's called the coronavirus. And these are the 4 strains which are circulating around the world each year. You've probably heard of the SARS. SARS means severe acute respiratory syndrome, and CoV is coronavirus. So 2003, there was an outbreak of SARS, and then there was a smaller outbreak of Middle Eastern respiratory virus in the Middle East, the MERS. And then finally, we are here in 2019, the SARS-CoV-2. So what are the possible origins of this COVID-19? So I have to make a distinction, very important. HIV is the virus. The disease it causes is called AIDS. Same thing, SARS-CoV-2 is the virus. And then COVID-19 is the disease caused by SARS-CoV-2. So where did it come from? I mean, a lot of theories, but the one which is most accepted and seems to have gained ground is the natural selection in animal host before zoonotic transfer. Zoonosis means a disease which are transmitted from animals to humans. So the bats are most likely the reservoir hosts. Again, a lot of theories and speculation, but because the sequence identity of the SARS-CoV-2 in bats is almost 90% similar to what we have found in humans, they think that bats were the reservoir hosts for this COVID-19 causing virus, the SARS-CoV-2. The pangolins also are in the mix as another possible reservoir host from animals to humans. But again, not as close as bats, but again, a lot of other animals are being tested. I'm sure you know about, they've tested to make sure your pets like dogs and cats are not the reservoir hosts. So far, there is nothing to suggest that, which is good. The second part, so from a reservoir host, it came to humans, and how do we go from human to human transmission? Again, this is, initially there was nothing to suggest human to human transmission, at least that was what was reported by the WHO, but now we know that human-to-human transmission with droplet infection specifically, and to an extent contaminated surfaces are the transmission routes. So now we are here in the middle of a pandemic because of the spread in various countries. Okay, so the structure of the coronavirus. This is an electron microscope picture of the coronavirus. The most important thing to remember is the spikes, the spike protein, the S protein. They are the ones which latch onto the human cells. And once they are inside the human cell, they go undergo a structural change so as to infuse the viral membrane with the cell membrane. And the genetic material, the RNA of the viruses, enter the host cell, and then they get copied and produce millions and millions of copies, and then you have an infection. It has been known and documented that these spikes are binding to the receptors of the human cell surfaces. There's something called as ACE, angiotensin receptor conversion enzyme receptors. They are the ones which are most commonly found in the epithelial cells. They're also there in the liver, lung, and the kidneys. But the nasopharyngeal route is the most important route for these viruses to enter the human body. So this is the structure of the SARS-CoV-2. As you can see, the spike glycoprotein is what is being most studied at this time. It is a target for vaccine production. Then there is N protein, the matrix proteins, the E proteins, and then inside is the RNA of the virus. So what has been difficult and challenging is the fact that these spike glycoprotein is the one which is causing havoc. And why is it different than other viruses? This is a more closer look of the spike protein. It's an atomic level structure. As you can see, this is the most important point to remember, is that this spike glycoprotein has at least 10 to 20 times more likely to bind to the ACE receptors on human cells than the previous family of coronaviruses. So as you all know, the viruses become smarter and smarter because we are trying to outsmart them, and then they try to outsmart us. So eventually that's where we are with this S glycoprotein, which has a 10 to 20 times more affinity and binding capacity. I think that's one important point to note that makes the SARS-CoV-2 or the COVID-19 to be different than any other family of the coronaviruses. The sequence and the structure of SARS-CoV and CoV-2 are very similar. And there are 3 different antibodies that suggest that unique vaccines and antibody-based treatment. We'll talk about the vaccine and where we are with that. But again, the drive home point for the day is that the ability of the S spike glycoprotein to bind to the ACE receptors on the human cells than the other coronavirus family makes it very unique. So as I mentioned here, the highest ACE2 expression is in the nasal epithelial cells throughout the respiratory system. As you all know, the respiratory system, nasopharyngeal and oropharyngeal route are the most important point of entry for these viruses. It can be contracted from animals and humans alike. We have talked about the main animal reservoir as most likely the bats. As I mentioned, the ACE receptors are also found in the heart, kidney, and the lungs. Even though the SARS-CoV-2 affects predominantly the respiratory system, the cardiac manifestations can be devastating. They can affect the kidneys and the other organs, which we'll talk about. The S glycoprotein gets into the cell and the genetic material is released into the cytoplasm. So this is predominantly the nutshell of the life cycle of the SARS-CoV-2. So what about human-to-human transmission? Obviously, again, there has been various theories and speculations and some documented cases. But most important thing, there is no question, is it's via respiratory droplets when a sick person coughs or sneezes. I think, we can talk about the society's acceptance and compliance with these wearing the mask, simple thing like mask. And again, what type of mask to wear, and even just a cloth covering is enough, is very important to at least reduce the spread of the disease. The challenging part also is that majority of the people are asymptomatic. So that's the challenge. And then, you get into this psychological thing that, well, everybody has COVID unless proved otherwise. Now, in the height of the pandemic, it's probably better to think that way. So that's good. Now, I'll tell you our experiences here and then the experiences there right now. In March and April, my thinking was, when I went to the hospital, every person I came in contact with is my colleague, nurses, anybody, I said they are COVID unless proved otherwise, which was actually helpful because at least you have the mindset to pay attention. Now that we have gone from red to yellow to just green zone a couple of days ago, the level of intensity of that part has to reduce a little bit, because it's very difficult to eliminate the virus, but you can deal with the virus. What I'm trying to say is basically that we don't want to be stuck with months and months or years of this where you just can't get on with your life. So you just have to adjust. So you still take precautions. I still have my scrubs on. I don't wear anything. So when I come back from work, I put it for wash. So I'm taking all the precautions, but at the end of the day, you just have to get used to it. What we did in March and April, where we were on the height of the pandemic in India and other parts of the world, including Brazil, and that's where it should be, where you have to be extremely vigilant. But the most important part is that, yes, the pandemic or any epidemic have seen, it has the tide and then it'll come down. When it comes down, you'll be happy, but you just have to wait, and that too shall pass. There is something called as basic reproductive number. It's called R0, which means if there is any virus, if one sick person will get an infection, how many other people get infected. So if the R0, which is the basic reproductive number, is more than 1, then the chances that the epidemic will increase are higher. So what is the R0? The basic reproductive number for COVID-19, SARS-CoV-2, common influenza. The flu is there every year. We get the flu vaccine. They have a different strain. They come with the vaccine. It's probably about 60 to 80% effective, but at least it helps. So the flu vaccine R0 is 1.3, whereas for SARS-CoV-2, the R0 is 2 to 3. So the infective ability is much higher. How about the symptoms? You can be asymptomatic, obviously positive, but mild symptoms could be stuffy nose, runny nose, sore throat, cough, and fever. And then moderate and severe cases can have fever, cough, shortness of breath, muscle pain, and tenderness. But most important, tiredness, sorry. Most important 3 things to remember are fever, cough, shortness of breath. Fever, cough, shortness of breath. As you all know, the incubation period is approximately 14 days. But symptoms typically occur 5 to 7 days after exposure. Starts in the nasoepithelial oropharyngeal pathway and then can lead to pneumonia and serious infection. So these are the populations or patients at risk. Age more than 65, people who have cardiovascular disease, people who have chronic respiratory disease like asthma or COPD, people who have malignancy like cancer or on treatment for cancer because they become immunocompromised when they're getting chemotherapy, etc. People with renal disease on dialysis, obesity, and patients who are immunocompromised. There is also some racial predilection, especially in the US. The number of deaths in the African American and the Latino population was much higher than the other races. Now, is it related to just racial characteristics, or is it related to more socioeconomic factors? Kind of needs to be determined. As you all know, the number of Asians in general Indians, Filipinos getting infection, and the mortality was much higher in United Kingdom because most of the National Health Service in UK is predominantly run by people from Asia. So you can see that that is contributing to a significant higher number. Again, is it because they're working in that line, or is it because there are some racial characteristics which makes them more susceptible? It is to be determined. Now, the common questions we get, especially from younger people, or some of the younger people, not necessarily all, is, well, it only affects elderly people. I don't have to get worried. I think that's a little bit of selfish way of thinking because their parents are older and their grandparents are definitely much older. I have seen patients who are 70 and 80 who had COVID infection, had respiratory illness, recovered. And you've seen patients who are younger with none of these listed here, die from the disease. So why does it have this discrepant affection? So I think one thing I would like to know, let you know, is most important is the concept of the viral load. Viral load is the amount of viruses which enter your system. For example, if somebody is mildly symptomatic and you came in contact with them, and the amount of viruses which they transmitted from the droplet infection to you is as a smaller number, then the more likely that you're probably going to get away with a mild infection. On the other hand, if you were exposed to we have these nursing homes in the United States. They're different than the nursing homes in India. Nursing homes are elderly care homes where they're already elderly, most of them, and then they are in a group home, and then there is a viral load, and then it can pretty much wipe out that elderly home. And it did happen literally 3-4 miles from me. There was an elderly home where 31 people died within a matter of 1 or 2 weeks, because again, it's the viral load, which is extremely important in understanding why some people get away with it and some people do die. So it does not spare anybody. It doesn't spare any age. Yes, the people listed here are more prone, but it doesn't mean that the other people are not at risk. So you should not take this lightly. And again, this is, especially in democratic countries, the question becomes, whenever you have something as a public health measure, the first question they ask is, why should I do it? I think that's a disadvantage, but we live in democracy. But I think if you have some concern about yourself, which is going to be there because obviously you want to survive it, but you should also have some concern for the people around you, would be my sincere wish, so that at least you can reduce the burden of this disease. So mainly, as I said, it affects the respiratory system. It can cause pneumonia. And then there's something called as ARDS, acute respiratory distress syndrome, where all your lungs and air sacs are filled and leaking from blood vessels. The lungs, which are like in hollow, empty spaces, which are oxygenating, are filled with leaking from the blood vessels. Again, this might sound very basic for some of the physicians, but it's important for the other people to understand that this pretty much causes lack of oxygen, hypoxia, and they're unable to breathe, and then they require ventilators. It can cause sepsis because it affects the whole system. Then there can be super infection, which means you already are under attack by SARS-CoV-2, which is the coronavirus 2. And then on top of it, you can have a super added bacterial infection or something else which will take you down. So it's extremely important to know that. It can affect the other organ system, gastrointestinal system, and it can cause nausea and diarrhea. And there's a question whether there is any fecal transmission possible. There's been theories about it. Recently, just about 2-3 days ago in Italy, they were trying to figure out, in fact, they had the SARS-CoV-2 present also in December. As you know, there is a big trade between China and Milan in Italy. And there's a lot of travel back and forth. So they found some wastewater samples, and then they detected SARS-CoV-2 just a couple of days ago to say that it is possible. Obviously, is that the main route of transmission? No. Main route of transmission is still droplet infection. It is important to know that it affects the blood system, the hematological system, and it causes bloods to clot more easily. They have become thrombotic, prothrombotic. This is extremely important to know. And again, this was just like a happenstance, like they detected, we just kind of found into this. And when I say we, the medical community, the people on dialysis who need a dialysis access and a catheter, right? So they had started forming clots, and then their access for dialysis kept clotting whoever had COVID-19. And then they suddenly realized, wait a minute, why is this happening? And obviously the initial patients who got treated, we were just still trying to figure out. So they got the unlucky ones, but over a period of time, you realize that this SARS-CoV-2 does affect the blood clotting system and makes them more prone for clot formation. And those can cause problems, and they need to be on blood thinners. Now, this was not known initially because it's a new virus. And then now we are more vigilant and give them blood thinners. They may end up on blood thinners for a long time, or at least in the short time, so that they get treated. So this is one of the other things. I'm sure you will see all the forwarded messages on social media, WhatsApp, etc., that this is not a virus. This is it causes clotting disorder. Well, it is still a virus. It still causes clotting system. It's the effect of the virus on the coagulation system. So that, again, we're trying to remove misconception and try to tell the public that, better information, or the information we have at least, has to be reasonably accurate so there is no misinformation. Most important effect on the heart, the cardiovascular system, is they can have myocarditis, which is inflammation of the heart muscle. And why is that important? Because people can die suddenly from life-threatening arrhythmias. So we have seen in the height of the pandemic in March and April, you literally had a patient who you finished round on them, and then you finish the rounds and they were looking good, they're feeling great. And next thing you know, in 2 hours, literally 2 hours, suddenly they became either hypoxic, which means lack of oxygen supply, or they had a bad arrhythmia. And then from the regular ward, they ended up in the ICU. So the sudden, unexpected turn of events is the hallmark of this virus during the height of this pandemic, which is an extremely important thing to know. Why is the arrhythmia part important? I'm sure we're going to talk a little bit about chloroquine. Chloroquine has been used a long time, but in the setting of patients receiving multiple other medications, it can cause some arrhythmia. So we have to be careful that no medication should be considered a light, or we should not take light of any medication, because we call it drug interaction, which means one medication, you have 10 other medications right by side of it, and you have to pay attention to those things. What about the effect of liver and kidneys? It can cause enzyme elevation in the liver. It can cause kidney failure. People will end up on dialysis. I'm sure you have somebody who or a public personality who had COVID-19, ended up on dialysis, hopefully short term, and then the kidneys recover, and then they don't need, hopefully, dialysis for the rest of their lives. The big thing, another key term to understand is cytokine storm. It is intense inflammatory response. The immune cells in your body produce too many cytokines to fight the virus. So you just almost like, just let me throw anything what I have in my body against the virus, and that's called the cytokine storm. I just was mentioning that a patient who is apparently healthy just 2 hours ago with COVID positive can suddenly deteriorate, and that's the cytokine storm, a part of the COVID-19 related diseases. So diagnosis, again, we have come a long way with the diagnosis part. Of course, suspected symptoms. I told you 3 most common symptoms are fever, cough, shortness of breath. Fever, cough, shortness of breath. Loss of taste is an unusual and an interesting symptom people have. And in addition, they have myalgia, don't feel good, diarrhea, nausea, etc., etc. Now, the most important part of the testing is PCR-based testing. PCR is the polymerase chain reaction, which is basically trying to take the specific RNA sequence of the virus. And you usually do it with nasopharyngeal or oropharyngeal swab. This went through a significant process in the past few months. Availability of the test was not easy initially. Then they came up with the availability, then there is a cost, and there's also a turnaround time. So about 3 months ago, when it started, it was one of my colleagues actually had some symptoms, and he had to literally wait for 7 days to get a result back. Now, we are here in my hospital right now, where if you order a test now, it will be back in an hour or less. So the turnaround time is extremely important. How about the accuracy? Accuracy is probably in the range of, I would say, 60 to 80%. It's not 100%. We have had some patients who had classic everything going with what we think is COVID-19, but the test came back as negative, and sometimes we have presumptively treated them as COVID-19. And then sometimes you have to repeat the test, and then it does become positive. Why is that it's not 100%? Well, again, going back to the concept of the viral load, which I mentioned before. So if you have a bunch of viruses particles hanging in the system, especially in the nasopharyngeal pathway, you're likely to have a positive test. Whereas if they are very far spread, and then even the way you collect the swab, if you just do a brief swab and then send it, you're probably going to get it as negative. So I think even the testing protocol should be rigorous so as to increase the accuracy of the test. There are some classic findings on the chest X-ray and CT of the chest. CT meaning CAT scan. I'm just giving you one representative classic findings which we find in CAT scan of these patients. This to the left is the normal lung by CAT scan. And then this, you can see the lung tissue is replaced by all these infiltrates. And then the lung tissue is being destroyed by the COVID-19. This is one of the classic findings which we seem to see very, very frequently. So let's talk about the treatment vaccine. I think we are on time, so we have about another 20 minutes or so. I would really like to devote some time for interaction and questions, which is more important because, as I said, this information is available. I'm trying to make it very broad-based, the ones we definitely know, and some practical pointers. So supportive care and quarantine. Supportive care is just, treat symptomatically. Quarantine, obviously, that there is self-quarantine, there is institutional quarantine. In here, there was never, ever institutional quarantine, meaning that in New York was the peak when we had the COVID pandemic. And literally they used to have on billboards or on roads that if you came from New York, you self-quarantine for 14 days at home. That's pretty much the thing. There is extreme heavy public protest against the privacy. For example, in some countries like South Korea, and even in India too, that you are able to track the positive patients. It's just not possible in US because of privacy concerns. So if you ask somebody to quarantine themselves for 14 days, you hope and pray that they do. Whether they do it or not is anybody's guess. So that is one of the disadvantages of self-quarantine. If there is discipline in the community, like South Korea, it was possible that they were able to reduce it. But here, again, people just were told to quarantine, and whether they did, some of them did, some of them didn't. And that resulted in spread. You probably know that at least there were 100,000 deaths in the US, here mostly in New York. Hydroxychloroquine has its ups and downs for the past few months. We'll talk a little bit about that. Steroids, if you have been following the news and the trials, the steroids have been found to be effective. Again, none of these are specific treatments. The steroids are known to decrease the death rate by about 30% in a trial which was done in United Kingdom just recently. So the steroids are pretty much, they're suppressing the inflammation and decreasing the cytokine storm. And when to use them, how much to use them, and how long you use them is all questions, but they have protocols. But I think earlier use of steroids seems to be more and more gaining ground, because you don't want to start too late. You definitely don't want to give it to asymptomatic patients. If somebody has respiratory distress, you start them early so that at least you try to prevent or reduce the chances of them having a cytokine storm. So steroids are reasonably the mainstay of patients who have at least moderate or severe symptoms. Again, not definitive treatment, but definitely in the realm of supportive treatment, which will help. Antiretrovirals. Again, it is my opinion that these medications will probably be the mainstay at some point. And I will tell you why. If you remember the natural history of HIV and AIDS that came in 1980, scientists tried and tried and tried for almost 15 years to come up with a vaccine. We still don't have a vaccine, but almost after 13, 14 years, they were able to come up with very strong and effective antiretroviral medications where we don't worry that much about, if somebody has HIV positive or AIDS, that they can be treated effectively. So similarly, these are the two antiretrovirals which are kind of in the news, remdesivir, and the second one, Fabiflu, I think is the trade name in India, which just got approved probably less than 2 days ago. Favipiravir, which is marketed by one of the companies, I think it's called Glenmark. But bottom line is the antiretrovirals will probably have some mainstay in terms of treatment for COVID-19. Again, no definitive treatment. These are all the things which are going to help. Oxygen and ventilatory support. I'm going to touch about proning. What is proning, and people who will get better oxygenation when they have COVID-19. We already talked about anticoagulants, the blood thinners, because they're more prone to clot. And finally, convalescent plasma, which I think we should touch a little bit. So case of chloroquine. Again, different countries have different guidelines. It has been used in every country possible for the treatment. Whether it's effective or not effective is who we want to talk to. Some people say this is it. I'm reasonably sure that in India, the ICMR guidelines do recommend pre-exposure prophylaxis and post-exposure prophylaxis, as well as treatment for COVID-19 patients. There is no guidelines or recommendations for pre-exposure and post-exposure prophylaxis in US. But again, nobody's right, nobody's wrong. I think the ICMR has their own level of degree of confidence that this is effective. I do have my classmates and my colleagues in India who do take chloroquine every week. Well, if nothing is effective, causing any harm, it's not necessarily a bad idea. But again, it's a subject of debate, but it has been definitely used. Why is chloroquine so important? It has been used, since 1630. They called it the cinchona tree to treat malaria as quinine in 1630. So it's been there for a long time. It's been used for malaria, as you know, even though there's resistance right now. That is used in lupus and other diseases which affects your immune system. We do know that the hydroxychloroquine does alter the pH of the lysosome. So if you are able to alter the pH of the cell, which makes it more difficult for the viruses or any of the organism to kind of have a claim in your body, it may be worthwhile trying to use that. Now, the half-life of chloroquine is almost like 50, 55 days. So it does hang around in your body for a long time. So those who are proponents of the exposure prophylaxis, which means let us take it to prevent it, their argument would be that we're altering the cellular level so that it makes it difficult for the viruses. So that's the argument to use for prophylaxis. I'm sure you have heard other measures, including alternative, which is Ayurveda. I think the first day was Ayurvedic treatment or measures to combat COVID-19. My theory and my position is very clear. If there is something which is not harmful to your body and is able to boost your immune system and it puts you in a better position to fight the disease, I'm not going to discount any form of measures or treatment. As simple things as meditation, prayers, etc. There is something called as psychoneuroimmunology, which means your mind, your mental outset. I've seen again and again patients who have disease, who have cancer, who have a positive outlook in their life, are able to much better cope and fight the disease. Same thing here. It's something foreign in your body. If you have a stronger system and a mindset to fight it, there's no question that you're going to do better. And that comes to the non-COVID related effects on the human body, which we're going to touch again also. So prone ventilation, awake prone, like somebody who has COVID-19 and has a respiratory distress. Why is prone position? And Kannada says ulta mulko. So this is very important and it has found to be very effective. So as you can see here, the alveoli, which are the really, really small lung units, which are important in the oxygenation, are collapsed when you're in a supine position. Whereas if you go to prone position, you're able to recruit more and more alveoli that your oxygenation is better. So this prone position has been found to be extremely effective in the treatment of COVID-19 patients. And it's been used, I'm sure it has been used in some, in India where we are at the height of the pandemic. It's extremely important. Even Boris Johnson, Boris Johnson, who is the Prime Minister of UK, actually one of my classmates who is an anesthesiologist, their team actually took care of Boris Johnson, and there were two nurses who were literally on his side watching this prone position for hours and hours, and it was used as one of the treatments for him, and he recovered and he went home. So coming back to the other measures, the last part which I want to mention is the convalescent plasma. I think the pathologists in the blood bank are the ones who are involved with this. The whole concept is, again, for the people who are not in the field of medicine, is people who already fought the battle and they already have the ammunition. So you literally borrow the ammunition from them. So those who are exposed to COVID-19 and they developed antibodies, and they have the antibodies which are fighting them, and then, hey, why don't I give my antibodies which I have developed to somebody else who could get treatment? It's a great concept. It's not a definitive treatment, but it'll tide over the crisis. For example, you don't have antibodies. You didn't have time to make antibodies, and there was somebody who already made the antibodies. So you pull all those blood and take out the plasma, which has the antibody, and infuse it to somebody who is suffering and battling the COVID-19. And then you basically, literally, as I said, look, they had the ammunition to fight. They won the battle. So they're literally kind of handing over their ammunition to you and say, hey, take it, man. I have a few more of the ammunition. You fight it. And I think it was used. I have a friend in Delhi. The health minister of Delhi did receive this convalescent plasma treatment, and I believe he's better and he's in the regular ward. So I think that's another great concept. It requires a good coordination with the blood bank and the pathologists, and it has been used effectively. I'm sure it has been used in other places in India too, but it has been used in our hospital with very good success. But you have to have people willing to donate who have recovered from the COVID. And hopefully, if you pool the plasma of 10 people, at least you will have antibody from somebody. That's the whole concept. So I have another 10 minutes. I'm going to go through the vaccine and then the non-COVID related effects, which are important. And then I have a conclusion. And then, of course, questions. So there's an intense effort to come up with a vaccine, 140 vaccines in development. I think the most common question we get from the non-medical community is always, hey, why don't we have a vaccine? Why don't we have a vaccine? And it's not easy. And I'll tell you in a minute why. You have to find a target. The virus has a component, and then you have to use one component of the virus so that you're able to come with a vaccine which will make antibodies against that component. That's as simple as that for the vaccine, to put it very simply. But the challenge is the viruses undergo mutation, they undergo transformational changes, which lead to moving target, meaning you got something, and then next thing you know, they change course. We have great lessons to be learned with other diseases. For example, as I mentioned, HIV vaccine for 10, 15 years, we just couldn't get there. SARS outbreak in 2003, it affected a lot of people. They said vaccine. Next thing you know, by the time you said we have a vaccine, the SARS was gone in 2003, and then it didn't show up for another 6, 7 years. So that's the frustrating part of vaccine. These viruses are not like those measles, polio, mumps, rubella, which just stayed the same in terms of structure, and they were kind of the babies of viruses where they didn't mutate or anything, so we were able to conquer them. But now they have become smarter because they undergo mutation and transformation changes leading to the moving target. I think the most important slide for vaccine is coming up. I'm just going to leave that screen for 10 seconds and see if we can hit the target. So this kind of summarizes the vaccine development. It's a moving target, and hope that you hit the bullseye at some point. But as I mentioned, mutation and transformational changes makes it extremely hard for vaccine development. Not only that, you have to develop a vaccine. I have to change that because I kept looking at that slide myself, because you just can't get away from that slide. But I think it drives home a point about the vaccine. Vaccine has to go through, you have to come up with the component of the virus, then you have to come up with a vaccine you think it'll work, then you have to give the vaccine to animals and make sure that you make antibodies for that component, okay, and then you have to give it to humans, make sure they don't have any side effects from the vaccine, and you want to make sure also that there is effectiveness, at least maybe 60%, 70%, 80% of the people are protected from that vaccination. And then there is this whole thing about vaccination, about religious beliefs, skepticism. In fact, I was telling Dr. Shubha the other day that, there are people who are against vaccination. And there was an outbreak of measles in 2020 in the United States because some parents said that we are not going to vaccinate our kids. So that caused a measles outbreak in today's world, 2020, because of skepticism. And then there's a different way of thinking. Just because one child or one person got this, it doesn't mean that they're going to have side effects. You have to look at the whole picture. So what about herd immunity? Herd immunity is a great concept. Basically that, hey, why don't we just get everybody infected, hopefully with the milder form of the disease, and then they become immune. The whole community becomes immune because you're creating a immunity in the population. So there have been various percentages which have been thrown around, at least how many of the percentage of people in the community have to get infected. And that number is between, they say 60, 70, 80%. And some parts of Europe, in fact, they're trying this approach of herd immunity, which is a little risky because you need to control. You need to control the amount of patients who get infected. and most importantly, that you hope that they just have a milder form of the disease and don't have a undesirable outcome, which is the death. So there are two ways to do herd immunity. One is vaccination, polio. Thursday, we get all babies polio, and we've been able to conquer polio to a major part. And that's herd immunity, which means you're protecting the whole population with vaccination. The issues with vaccines, especially with the newer viruses, now I'm not talking about the older viruses, is the length of protection and the need for revaccination. Sometimes you have heard of booster dose because the amount of antibodies goes down, and then you have to revaccinate them. There are religious objections on vaccination in some groups. Then fear about risk, which I mentioned briefly. There was a celebrity whose kid got some form of side effect, and that celebrity went on a campaign against child vaccination here in the US. And that led to, because people listen to celebrities for whatever reason, and then then they start, they said, no, I want my kids not to be vaccinated. And the next thing you know, there's an outbreak of the disease because you're not vaccinating the whole population or close to the whole population. Then there is this part, which is skepticism, which means if I come, okay, the honest question would be, if there is a vaccination today, will you take it? So that's the skepticism part, because we want to make sure it works, number one. Number two is it doesn't have side effects. So as I already mentioned, natural infection by herd immunity, which means most people get infected. It's ideal, but difficult to control and execute this herd immunity concept. It just has to happen. We just can't clearly plan it. It just has to happen. We hope it happens. And at some point it will happen for COVID-19, but it's going to take a little while. So a few points about healthcare workers, public health officials, everyone who is in healthcare field, no matter what their designation is, if they are exposed to the setting, they are COVID warriors. It includes the people who are in cleaning the room after the patient get discharged. In fact, they are as at risk as the physicians and nurses and respiratory therapists. But obviously, there are in the healthcare field, there are people who are more prone. Respiratory therapists, they are the ones who give breathing treatments. They are the ones who are exposed to all these droplets. So they are high risk. If you take the physicians specifically, emergency physicians who come in contact with emergency patients, anesthesia, critical care physicians who are in the intensive care, taking care of these patients day in and day out, obviously critical care nurses, and ENT physicians who literally are in the phase of this oropharyngeal and nasopharyngeal areas are the highest risk. But as I said, whoever is in the healthcare setting, they're all at risk. So what do we do? PPEs. There's a lot of discussion about what kind of PPEs, when to use, how to use. We can probably leave that for the question and answer session. And basic precautions, like hand washing, social distancing, you all know about it. So there's no need to belabor that point. Most importantly, it's a team approach. Team approach means there are 4 physicians taking care of the same patients. And if there is trust and a team approach with all the physicians, that you basically reduce the risk of exposure to that patient, at the same time take care of the patient. What do I mean by that? If there are 4 physicians and then there's one physician today who is going to see the patient, evaluate physically, and then have the data, they can have an approach where all the 4 physicians don't necessarily have to see the patient, because you trust your partner's decision making in terms of examination. And then you have these virtual visits, etc., but you just have to have a team where you have to have trust in your team members. And then they say, look, we're all at risk, but let us share the risk and then try to reduce the risk. That should be the goal, as opposed to, well, COVID, I'm not taking care of the patient. Well, I'm not going to see this patient. Look, we took the Hippocratic oath that we're going to take care of this patient, so it is our duty to give service to the humanity. But again, don't go without ammunition, which is the PPE in this specific case, is my kind of take on this whole issue. This is extremely important because we cannot ignore this. what are the non-COVID related effects to the community about the health? People get anxiety. People have obsessive compulsive disorder. Of course, you need to wash your hands, but if you don't have to wash your hands like 122 times every day. Anxiety, depression, and loneliness. I do know personally people in the past 3 months, they have not moved out of their house at all. We're not talking about people who are 70, 80 with medical problems. These are people who are healthy and then 40 and 50, some of them I know that they just haven't moved out of the house. Now, do you think they're right? Well, they're right in their own way, but that does lead to more mental issues where my goal is always be in the middle, which means take precautions, but get on with the life. Which, for example, if you're in a less crowded area and you're allowed to take a walk, there is nothing wrong in taking a walk. You can make a case that, hey, it's in the air, I might get sick. Well, that is taking it to too much of an extent, in my opinion, that we just need to be cautious, but not be so overcautious that you will develop so much of other mental health issues. That's where your reliance on yoga and any other things which will help clear your mind will come in to picture. Because for us, most of us who have been blessed with not to worry about day to day that whether there's food on the table, just remember there are people who just say, well, I don't care because I need food on the table. So we just have to, at least the public health officials and the government need to pay attention to the people who literally sometimes have to choose between, I'm going to take a risk on COVID, but I don't want food on the table. So I think it has to be taken in perspective for the whole community, just not worry about treatment. How do I prevent it? Yes, these are all good. But again, you have to look at the whole community because that's ultimately where we are here. I did put health first and economy next, because in this world, they'll say, well, lockdown is not good for economy. Yes, that is correct. But if you're not here to discuss it, then there's no point. So I think the health comes first and the economy definitely comes second, but they are tandem. But I did put health first and the economy second. So in conclusion, I do have one more extra minute, and that gives me time to conclude. I hope I gave you a whole overview of why COVID-19 has been more effective and has had success against the human population, but there are threats and challenges and how to reduce the risk. So SARS-CoV-2 is a new virus. It is genetically related to coronavirus responsible for SARS outbreak in 2003. Most important part which we did discuss is SARS-CoV-2, which causes COVID-19, has the ability to bind 10 times more tightly to its common host cell receptor. That's a very important concept, why COVID-19 is wreaking havoc. The ability to attack different organ system. There are some things unique about COVID-19 in treatment, which we have just realized because it's all new. Threat of asymptomatic and minimally symptomatic patients to spread in the general population. The mortality is why we are here to talk about it. As I just mentioned earlier, that if it didn't kill so many people, we wouldn't even be talking about it. We would be going around the way and say, hey, stop sneezing or cover your mouth and move on. But it's 2 to 10% mortality depending on the geographical characteristics. I think that's where the whole global challenge is right here. Because deaths are precious. If it's your family member, it becomes more precious, and that's when it hits your family member that you're in a whole different ballgame. Elderly and people with comorbid conditions are at risk, like we talked about. No specific treatment is available yet. We talked about the vaccine challenges. And I finally would like to take time to acknowledge my daughter. She's in high school. She was helpful in preparing the slides for me, which was a great help. And I believe we are down to the hour, and I will stop sharing. Okay.
Yes, sir. Thank you very much.
Yes. Okay. So